So, Jack, thanks for joining us today. And first of all, it's great to see everybody. It's been 2+ years. We've been doing these virtually, and it's great to be back in person. This is an event, Future of Healthcare. So let me tee it up for you. What is the future of healthcare, both short and long term for physicians, but also patients?
That's a good question and a really that's a good question and a pretty broad question, I guess. Future of healthcare, I could talk about almost anything. I think, as I took my oath as president of the AMA about 3 weeks ago, so I'm relatively new in this role, and I feel like I'm taking it on at a really interesting time for my colleagues in medicine. I look out and think about the 2.5 years that they have lived through and this point where we are in the pandemic, and there's a lot going on. First of all, I've never been prouder to be a physician as I think about what physicians have really endured these last 2.5 years. Fortunately, we're no longer at a point where people are not having enough PPE and wearing trash bags to protect themselves at work or sleeping in garages to protect their families, but physicians have endured a lot of disinformation, a lot of anti-science aggression, and have really done a lot, I think, to educate the country. So I just have great pride in that. I do think we've reached a point where it's time for the nation to actually renew its commitment back to physicians. So at the AMA, we are thinking a lot about and talking about a recovery plan to kind of help healthcare going forward. So we can talk about some.
Talk a little bit about that. What's in the recovery plan?
So a piece of this is really just dealing with burnout. As I look at my colleagues around the country, there is a tremendous amount of burnout coming out of these 2.5 years. And some of that we don't even have, with the stigma around mental health and physicians not being able to, sometimes if they're depressed or at risk of suicide, do things about that. So that's one of our pillars. There's another that's really focused on the actual obstacles and burdens that get in the way of us providing the great healthcare to patients that we went into medicine for. So whether that's things like the prior auth process just to get people the medications they deserve, or dysfunctional technology around EHRs, that's electronic health records, that still don't work well. Thinking about the future of Medicare, thinking about raising up physicians as leaders of healthcare teams. And then the fifth pillar is really around technology. And so more in line with, I think, some of the things you'll be talking about today. Physicians were not on the ground floor of innovation a decade ago. So if you ask the average doctor, what do you think about your electronic health record? They're going to say, well, this was clearly not designed by physicians for physicians, right? So as we think, whether it's telehealth, whether it's augmented intelligence and some of the cool new tools that we have, we really want to make sure physicians are involved early with sort of our lens and our values to make things useful so they actually affect health of patients.
You're going to be testifying later today. I want to ask you about government involvement in healthcare. Obviously, we've seen a huge Supreme Court decision. What are you going to be saying later today?
It's a really dangerous time for doctors and patients. I think if you've watched the news the last few weeks, initially it sort of seemed like anecdotes of what was happening in some of these states with patients showing up in emergency departments with ectopic pregnancies or complicated miscarriages with an infection or something else, that literally physicians are finding themselves in a place where they are stuck between their ethical responsibility to take care of the patient who's in front of them and do the right thing to save a life or improve the health of that person. And they're at the same time facing a web in some of these states of conflicting and very confusing laws. Some of the laws that have gone into effect literally were on the books from the 1800s, far before we had sort of the modern healthcare world that we're in today, and others that have been added more recently. So literally doctors are having to pick up the phone, call hospital attorneys, and get permission to do basic things in healthcare when lives are on the line and minutes matter. So doctors are incredibly frustrated right now. They're pretty frightened about these situations, and we are trying to be very clear to policymakers just how dangerous it is to be a physician and feel like sitting on your shoulder is a state attorney general or a state legislator or somebody else who's going to be second-guessing that care. It's so wrong to have politicians and government inserting themselves into these decisions that really should be between patients and their physician.
What do you think is the answer?
Well, in the past, our remedy when a state made a bad decision like this was the courts. But with this Supreme Court decision, that remedy, I can't sugarcoat how hard and how dangerous this is. So part of it is just convincing states not to pass some of these laws. We'll win some of those battles and lose others. And there will be other opportunities to litigate. So you saw the administration last week put out guidance on a law called EMTALA. Many of you may be familiar with. This is a law that basically says when somebody shows up in your emergency department unstable or at risk of death, regardless of insurance or anything else, you have to take care of the person in front of you. So we were very appreciative that the administration actually put out guidance that supersedes any state law. But then you have Texas actually suing to disagree. So the physicians are still in this very uncomfortable position where they don't know if their decisions to take care of the person in front of them are actually going to be criminalized, if they're going to face, in some cases, felony jail time, again, for taking care of the person in front of them who may have a dangerous ectopic pregnancy, who may have a complicated miscarriage. There are all kinds of scenarios. The other thing we're seeing is this is spilling over into other drugs. So I happen to be a dermatologist in my day job. There's a drug called methotrexate we use for a lot of things in healthcare, cancers, autoimmune diseases. Well, doctors are now finding that pharmacists in some of these states are refusing to fill prescriptions for methotrexate because it happens to also be used to treat ectopic pregnancies, and they're scared of the state coming after them. So we have an enormous amount of work to do to try to mitigate some of these challenges so that patients' health can actually be protected. But it's a really challenging moment.
What do you think, obviously, the role of telehealth has exploded post-pandemic. A lot of people, including myself, never had a telehealth appointment, but I think most people have had it. Where do you see that going, and how valuable is that?
Well, there are very few silver linings to COVID-19, but I think the explosion in the use of telehealth over these last 2.5 years has been an amazing positive. In terms of the flexibility that it's granted, it's actually helped with some of the health inequities that we face in terms of making it easier to get access, to get in and see healthcare, see physicians. In the first months of the pandemic when offices had to completely close down and we were able to get Medicare and commercial insurers to actually turn on coverage for telehealth, which had been the big block for several years, we saw this enormous increase in its use. And it has settled back down to somewhere in between, which I think as we learned and figured out in each specialty, what are the things that telehealth is really good for? When do you actually need to see somebody in person? So that's been a big part of the evolving evidence, is actually figuring those things out. Interestingly, people may not know this, but the future of telehealth is a little bit at risk. So under the Medicare current law, when the public health emergency ends, a few months later, Medicare will revert back to the old rules, which essentially say if you're a Medicare beneficiary, unless you live in one of 2 states or an extraordinarily rural area, you can't get telehealth. And even if you can't use your own device. You have to go to a special presenting center. It's not consistent with current technology and really what's best for patients. So we've been working with Congress to encourage, and there are a number of bills actually under consideration right now to extend that. The commercial plans in the states are going to have to do the same thing and think about extending this access to this great new technology.
One of the big narratives of healthcare, and I used to cover it many years ago, is making healthcare fair and health equity. Where do you see that going? We've seen that with COVID too, that if you're wealthy, it's easier to get treatment.
Yeah, health inequities are not new in this country. I think COVID, in a way, pulled back the covers and made it very apparent to a lot of people who may not have known before the extent to which Black, Latino, Indigenous, LGBTQ, rural patients actually face as many health inequities as they do. It is a huge priority for the American Medical Association. We've been around for 175 years, so a piece of this to build trust in marginalized communities has been us reckoning with our own history. Because during those 175 years, we have not always been on the right side of health equity. So that's a big first step that we have been taking. But simultaneously, it has felt very important to me and to the AMA broadly, as we have invested in a health equity unit within AMA, that this not be a siloed thing. I knew it would be successful ultimately if we reach a point where your zip code or your race is not a major determinant of your health outcomes. But in the medium term, I know our work is on the right track when I see that it is affecting every unit in the organization. So whether it's our medical education team that's thinking about the pipeline of future physicians that needs to look more like the populations we serve and be more diverse, or medical school curricula that need to prepare future physicians to actually go out and reduce health inequities, whether it's our chronic disease group that is actually meeting different communities where they are and making sure that we're in the right places to affect, for example, a program called Release the Pressure that focuses on Black women with hypertension. Whether it's our litigation group that has gone after FDA in the past for not regulating menthol in cigarettes, which has had devastating consequences for generations of young Black men who have been targeted by tobacco companies. And again, whether it's our innovation team, so people don't think about this much in the innovation space, but we have seen really fantastic, exciting things happening in innovation. But if you don't start with an equity lens at the beginning, if the right diverse people are not in the rooms with entrepreneurs and funders and physicians who are thinking about health equity, you end up with tools that maybe not on purpose, but tools that actually cement inequities, like AI tools that learn from existing inequities and actually build them into the decision-making process. Right. As they do their machine learning. You saw probably the example of a large major national insurance company who created a tool with good intent to try to identify patients with chronic disease who are likely to get worse in the next year and need hospitalization, and so they could target additional resources to help those patients. But the tool learned from our existing expenditures, which are based on who has access to healthcare. So if you put the exact same patient into that tool with the same chronic diseases and the same medical record, but just change their race, it would steer all of the resources to the white patient and not the Black patient. So as we think about innovation, we are thinking a lot about and have fantastic people that we brought into our team with real expertise in this area and external advisory groups so that we can make sure that future innovations actually help us to solve equity problems.
Well, we've run out of time. I know you have to testify. Please thank Dr. Jack Resneck for joining us this morning.
Thanks so much.